But as I mentioned in previous meetings, we were going to bring some speakers to the table. And I asked Paul Thompson at the CVCT meeting in December, would he mind coming to speak on lipids? And what is a lipid expert and why is it important to the post-transplant community? And he said, sure, I'll do it. And then I actually took him up on that offer, and now he's here today. So I know he's his favorite speaker, but I have had the opportunity to hear him present many times over the years, although it's not typically on a lipid talk that I'll go to. It's more a sudden death in athletes thing that Paul's also interested in. So I'm going to ask you all to put yourselves on mute for a minute, and I'm going to hand the stage over to Dr. Paul Thompson, who's coming to us from Hartford, Connecticut.
Great. Well, thank you for having me, Lisa. And it's nice to talk to all of you folks. You know, I don't want to do it that differently from how you've done it previously. In other words, if you have questions, I want to get to them fairly quickly. But I put together a few slides just so it would give you some sort of a background. And so I entitled this, I just took it out of one of my other talks. I give a talk that says, what do you need to know to be a lipid expert? Because I don't think it requires a lot of skill. So what can you do to lower your LDL without drugs? Because everybody wants to not have to take drugs. Now, why should you try to lower your LDL anyway? You know that about 50% of people who have a transplant will have trouble with narrowing of the heart arteries, the arteries that crown the heart. Now, you know, if you think of a coronation, those arteries crown the outside of the heart, and that's why we call them the coronaries. And what happens to the coronaries typically in people without transplant is over time, they get deposits of cholesterol. The same thing happens with people who get a transplant, but it's a different sort of deposit of cholesterol. What happens is it's not so lumpy bumpy the way it is in someone who doesn't have a transplant, but it's more kind of diffusely throughout the vessel. So it's a generalized narrowing of the vessel. And what it's been shown is that if you treat people with statins, you can reduce the rate of that thing. So what can you do to lower LDL without drugs? Because I get a lot of this stuff about, oh, I don't want to take a statin. Those things aren't good for me. Well, you can pick new parents. That's basically the way to lower your cholesterol without drugs. Or you can follow extremely low saturated fat diets, or you can become a vegan, or you become a vegetarian. A vegan eats, you know, no animal products at all, so not even milk, not even eggs. Or you can become a vegetarian or become a fish-eating vegetarian. You can ascend the ladder of food, but basically, it's tough. It's tough to do it, and you'll never be able to achieve what we can achieve with the lipid-lowering medicines, which are really remarkable. And I know everybody gets all upset about, oh, I don't want to take those drugs. But remember, statins were found in fungi. And if you go to a food, one of those lines where you can get your salad, those umbrella mushrooms that they have, loaded with the statin, lovastatin. So there's a lot of statin in the environment. They're actually made by a bunch of bugs working for the drug companies. So what do you want to do to lower your triglycerides? Because triglycerides are the other big problem. Well, you can pick new parents, or you can lose weight. Now, why did I say lose weight? Losing weight improves insulin sensitivity. So I'm going to show you this just in a minute, but a lot of people don't know this. One of the biggest causes of high triglycerides is being insensitive to insulin. Or you can exercise like crazy. It takes a lot of exercise to lower triglycerides, but when you exercise, aerobic exercise, your muscle eats up the fat that it has in it to use for the exercise, and then it has to replace that fat, so it sucks that out of the blood. Here's a study we did years and years ago. I can't see it, but I think it's way back because you're all hiding on my slide, but it's way back in the 80s. And what we did is we took people and we looked at the change in serum triglycerides the day after, here's 24 hours, okay, that first dip, 24 hours after exercise. So these are some people that weren't fit, the open triangle, and they exercised for 30 minutes. Here they exercised for an hour, and I mean, we whipped them. And so the day after exercise, their triglycerides went down. Now, these are some trained distance runners, running an hour, 2 hours, 3 hours. And you can see that the more exercise they did, the lower their triglycerides were the day after exercise. They didn't have to do, years and years and years. They just had to exercise acutely and hard for one day. Why? Just like I said, when you exercise, you eat up triglycerides in the muscle. They have to be replaced, so you take it out of blood. But I say expecting patients to cure their lipids by diet, exercise, and weight loss is like waiting for Godot. That dude never showed. Remember that in Samuel Beckett's, he never showed up. And that's what often happens. So I wrote this paper, Confessions of a Drug Dealer. Now they're all legal drugs, but medicine is not a morality play. Sure, patients should exercise, eat right, lose weight. All that stuff, but it's hard. And your arteries don't really care how you achieve low LDLs and how you achieve low triglycerides. So this is the no judgment zone. If you don't want to be a vegan, I don't care. I just want your cholesterol levels down. And you know what? That's what your arteries want as well. They don't care how you got there. Now, I want to just tell you, this is very complex, but I'm going to make you I got to make you lipid experts, right? It's just really quick. So this is the liver. I have to explain that to cardiologists because, they don't think there's anything under the diaphragm, but this is the liver. And what happens is you get energy from all sorts of places. One place is the fat cell, but you can also get it from food, from, eating fat, from eating carbohydrate, and it goes to the liver and it's made into this thing called acetyl-CoA. It's worked on by this enzyme and it's made into cholesterol. Then cholesterol, alcohol, cholesterol is actually an alcohol. Now you can't drink it, but it's an alcohol. And then if you add a little fat particle to it, it becomes an ester. It gets shipped out as these things out of the liver called VLDL, for very low density lipoprotein. Why are they very low dense? Because they float. Things that have a lot of fat float. And so these little particles, when they're sent out of the liver, they got a ton of fat. And then there's this enzyme called lipoprotein lipase. And what it does is it takes the triglycerides out. So now it gets less and less buoyant. And so it goes from being very light or very low density to just being low density. And this is the stuff, this low density stuff is the stuff that gets into your arteries. Now you got two ways to get rid of the LDL. What you want to do is you want to pick it up in the liver. You want the liver to take it up. This is called the high affinity pathway. Now, can you see me? So I always say to patients, like, look, I'm your liver. Now, not chopped liver, just your liver. And from my mom, I get one LDL receptor. That's just my hand. It's a little grabber. It can grab LDL. From dad, I get an LDL receptor. I can grab that LDL, okay? So as that LDL goes by, I grab it and I pull it into the liver by this high affinity LDL receptor. And you know what happens? When that cholesterol gets into the liver, the liver says, hey, day off. I got enough cholesterol. I don't have to make any more cholesterol. So the liver shuts down this enzyme. So what do statins do? Statins shut down this enzyme for you. And then the liver says, whoa, I need more cholesterol. I know what I'll do. I'll make more of these receptors. So the way you lower cholesterol is your liver grabs more of it out of the blood after you take a statin. Now, I always say the LDL receptor is green. So when I gave this lecture to the medical students, they said, really? It's green? You've seen one? No, it's recycled. Green, okay. It's recyclable. So what happens is this. Here's your liver. Where's my pointer? Here's my pointer. Okay, you see my pointer? Here's your liver. Here's the little LDL receptor. Here's the LDL. The LDL goes into it, comes into the liver. The liver takes the cholesterol particle, and the LDL receptor goes back out to do it again. Except if the LDL particle gets grabbed by this little thing called PCSK9. If it grabs that LDL particle, look what happens. Goes into the liver, and the whole thing gets broken down. So there are fewer LDL receptors on the surface of the liver. So in addition to statins, we have these drugs that we can inject you with, and those drugs block this, they grab this PCSK9. Okay, so here I am again. Here's my receptors. They will go around and around, except if they get grabbed by that PCSK9. And what we got is a drug that grabs PCSK9 before PCSK9 can grab the LDL receptor. Almost done. One other thing I want to point out, remember the fat cell. If you got a lot of fat coming out of your fat cells, you're going to make a lot of cholesterol and you're going to make a lot of triglycerides. Now, the thing that people don't remember, and you know this, and I'll bet your doctor doesn't know it because most doctors don't know, it takes more insulin to control fat than it does to control sugar. So when your doctor tells you, ooh, your diabetes is borderline, you're already well down the pathway to having frank diabetes. Because what happens is the fat is abnormal long time before the glucose becomes abnormal. Okay, I think we're done. Oh, we're all done that. Okay. Now, one other thing you need to know about, this is all the rage now. Now, when something becomes all the rage, what does it mean? It means some company has developed a way to treat it, and now they're going to create a market. So you can't go anywhere without knowing about lipoprotein A. We've been interested in it for 30 years and wrote papers about it in the 90s. But what lipoprotein A is it's a type of LDL cholesterol. And I want you to remember this, because you're going to want to ask your doctor, what is my lipoprotein A? Because if your LDL is good, but your lipoprotein A is high, you want your LDL lower. Lipoprotein A takes any cholesterol level and makes it more dangerous. It's genetically determined. Statin effects on it are debated. There are some things that lower it. It's also a risk for aortic stenosis. This is what it looks like. And what it does is it does all sorts of things. It causes inflammation. It causes cholesterol deposits. And if you can see, whoops, and if you can see it way on the other side, it also causes clots. I'm going to skip that, going to skip that, going to skip that. I'm almost done. So some experts in European guidelines think lipoprotein A should be measured in everyone. I do as well. I measure it in everyone. All right, one other drug. When I give you a statin, that blocks production in the liver. Now, the body is not stupid. So when the production is blocked in the liver, you know what the body says? Hey, I'm going to show him. I'm going to absorb more of this stuff. I'm going to suck more out of the intestine. So this drug, Zetia or ezetimibe, blocks the absorption of cholesterol in the gut. So what am I telling you? We got 3 ways to fix your bad LDL cholesterol and to decrease the chance that you're going to get narrowing of your arteries. Statins, great drugs, found in nature, now made by bugs and chemicals. The bugs that make it are working for drug companies. Second thing is we got these PCSK9 inhibitors that you can inject yourself with, okay? They add to what statins have done. If statins aren't enough, these will work. Third, we got this drug Zetia, ezetimibe, blocks the absorption of cholesterol in the gut. Okay. And this just goes to show that in a study that lasted 7 years, if you just were treated with simvastatin, this was your rate of heart disease. And if you were given Zetia, your rate was lower. Well, that's not a very big difference. It was statistically significant. But the reason it wasn't a big difference is they gave them so much simvastatin that their cholesterol levels weren't very high. So it's hard to show a big difference. But Zetia, ezetimibe, really lowers LDL a lot. And I want to show you a trial. This is called the Fourier trial. And what this is this is a drug called Repatha, and it's injected to people who are already on statins. They're high-risk patients, and I view it as a proof of concept. What's the concept? Even lower, when it comes to cholesterol, is even better. So here's what happened. This group got placebo. This group got Repatha or evolocumab. And over 3 years, 36 months, 3 years, there was a 2%. So if you treated 50 people, one of them didn't get a heart attack. One of them didn't get a stroke. One of them didn't get something with their vessels. And here's where the cholesterol levels were. This is what we thought was acceptable. We thought, oh, if you're under 90, you're doing okay. You're doing okay with your LDL cholesterol. They got these people down under 30. And if you were under 30, you know what? You did better. So the point is, even lower is even better. Okay, I'm going to skip the Rodney Dangerfield. We're going to skip that. Now, what about side effects? Oh, we'll do the Rodney Dangerfield because he's such a great guy. He's dead. So triglycerides, I think they're the Rodney Dangerfields of lipid management, okay? It's good old Rodney, because poor Rodney and triglycerides get no respect. Why don't they get respect? Because people forget they're an early sign of diabetes. Okay, we'll skip that. Now, I've done a lot. This is one of our papers. I'm interested in the side effects of statins. Published a lot about it. This was in JAMA when they asked me to write a what to believe about statin-associated side effects. The point of the matter is that we took 400 people. I took 400 people, double blind. I gave them high doses of atorvastatin, 80, or I gave them placebo. I didn't know. They didn't know. We measured muscle strength. We measured symptoms. 10% of the statin people got symptoms, 5% of the placebo people. So we think the true incidence is only about 5 in 100 who actually get muscle side effects. So everybody's worried about it, but it doesn't happen very much. One thing to remember, and that's the statin rule of 6. And what does that mean? Doubling a statin only gives you a 6% reduction of the baseline value. So if I'm on, suppose Lisa puts me on 20 of pravastatin. She says, Dr. Thompson, yeah, cholesterol level, I can't do a good New Jersey accent, I'm sorry. So she puts me, my cholesterol's 200. She puts me on pravastatin 20. That will give me a 25% reduction. So I go from 200 to 150. Not enough, Dr. Thompson, you got to get lower, because I know that even lower is even better. So she decides to double the dose of the statin. I only get a 6% additional reduction. So I only get another 6% of the baseline value. I don't go from 150 to 100. Remember, I went from 200 to 150. I go from 150 to 138. So you get the greatest percent reduction per milligram of drug at the lowest drug dose. Okay, so we can often get you on low doses of statins without side effects, and then add Zetia or add a PCSK9 inhibitor, one of those injections, and we can get you quite low. This is a study we did where we just gave rosuvastatin on Mondays. This was 40 people. 38 of them got rosuvastatin on Mondays and Thursdays. That's it, Monday and Thursdays. 2 got 10 milligrams, Monday and Thursday. And look what happened to their LDL. After 4 weeks, they got a 26% reduction. Now, 5 milligrams is the daily dose, right? We gave them the daily dose twice a week. Why? You get the biggest reduction with the very low doses of the drug. Okay? So that's all I wanted to talk about. That's the introduction. I did not hear you guys applauding for the jokes. But that's okay. You know, I can take it. I'm a big boy. Thank you, Lisa.
I had them on mute.
Now we're good. Yeah, that's right. Yeah, I'm on mute. Good. So my wife
Okay.